Hello and welcome to today's Center for Healthcare Strategies webinar on data definitions and common measures for the use of psychotropic medications, part of the ongoing Psychotropic Medications Virtual Learning Community webinar series. To eliminate background noise, phone lines are being muted during today's presentation. There will be 2 question and answer sessions held during today's event, and instructions for participation are shown on the screen at this time. If you experience technical difficulties today, you may dial 866-229-3239 for assistance. Today's event will be recorded. Slides and a video archive will be available on the CHCS website in the next week. At the completion of the webinar, we ask that you complete a very brief online evaluation that will pop up on your screen. Your feedback is very important to us, and we hope you're able to complete the survey. I will now turn the webinar over to Kamala Allen, Director of Child Health Quality at the Center for Healthcare Strategies.
Thank you, Travis. Today's call is for a broader audience than is usually invited to attend our webinar series. This is because we want to share this information as broadly as possible, knowing that measure development activities are going on in all corners and that what has been developed through the Data Workgroup process might be useful as those efforts move forward. As a reminder, this webinar series is designed for state agency officials and staff who are involved in the oversight, monitoring, and payment for psychotropic medications for children in foster care. We're bringing together support from the Annie E. Casey Foundation and the Child, Adolescent, and Family Branch at SAMHSA to present these webinars. The cooperative agreement with the Administration for Children and Families is enabling us to disseminate technical assistance resources that we've developed in response to the needs of our Psychotropic Quality Improvement Collaborative participant states, which is funded by the Annie E. Casey Foundation. These 6 states, which you see on the screen, are Illinois, New Jersey, New York, Oregon, Rhode Island, and Vermont. This 3-year system change effort is addressing all aspects of oversight and monitoring for psychotropic medications. If you were able to join us on our first webinar where we talked about agency consent policies, this will be, I think, a very good follow-up to that because as we believe here, data is necessary to drive quality. These webinars are intended to be part of a how-to technical assistance offering, not just to introduce a topic, but to help the audience design and implement the key elements of an effective oversight and monitoring process. The integral part of the model requires states to have data about key aspects of the system and how it's serving the population. This data is critical to driving towards high-quality care and better outcomes. When you registered for the webinar, a subset of you also responded to a survey that was associated with today's topic. There were 18 respondents, and just very quickly wanted to share what we found based on the responses we received. 2/3 of those respondents indicated that their agency collects data on psychotropic medication prescribing rates for children in foster care. Just under 75% of those indicated that this data comes from Medicaid claims. While there certainly remain some concerns about the accuracy of non-Medicaid claims data, 71% of the respondents believe that their data accurately reflected prescribing rates. We believe that's important because we don't want perfect to be the enemy of good, meaning that we need to have access to data and use the data that we have to at least have some idea of what's going on within our systems and for the populations we serve. And that leads to the last item that we asked about, how states are using those data. Just over half of the states that responded indicated that they have some type of red flag system that allows them to identify potentially concerning prescribing patterns. In short, there's much we can do to ensure effective oversight and monitoring of psychotropic medication when we have targeted the right indicators and have good data in hand. Next slide, please. Today's session highlights the work of our data subgroup, as we call them. A group of state representatives that have been impaneled as part of our Psychotropic Medication Quality Improvement Collaborative. Once quality improvement or system change projects are laid out by our project teams, the work group is convened to execute against a 2-part charge. The first part of that being to identify common data definitions for the project teams to use for concepts that are being addressed across the states. And secondly, to identify common measures that can be used to collect and report impact data on key indicators so we can measure the impact of the collaborative as a whole. The purpose of today's webinar is to share the outcome of the work of the Data Workgroup so that for where it's relevant for work that others are doing, these data might inform those efforts. Our intent was not and is not to recreate the wheel. So where work had already been done in some of these areas, either by individual states or national organizations or by bodies impaneled by the federal government, we've incorporated that into the recommendations that were put forth by the work group to the 6 states that are participating in the collaborative. If ultimately we can increase the number of states using the same data definitions and measures, then that we believe would be a real contribution to the field. Next slide, please. So finally, I'd like to acknowledge the contributions of the core members of the Data Workgroup for their thought leadership in this process, including Dr. Christopher Balanci, who served as our workgroup chair. The individuals who served on the workgroup are listed here, and I just want to, again, say thank you for their time and effort and bringing resources to the group for consideration and adoption. So without further delay, I'm going to turn it over to Jessica Lipper, a program associate here at CHCF, to introduce our speakers for this afternoon.
Thank you, Kamala. And thank you again for participating in today's webinar. We have 2 distinguished panelists today, Dr. Christopher Balanci and Dr. Molly Finnerty. Dr. Christopher Balanci is a board-certified child, adolescent, and adult psychiatrist and assistant professor in the psychiatry department of Tufts University School of Medicine and the senior psychiatric consultant at Walker in Needham, Massachusetts. Walker is a multi-service agency working with children experiencing severe emotional and behavioral disorders secondary to major mental illness, trauma, and developmental disorders. He is president of the American Association of Children's Residential Centers. Dr. Balanci has consulted to the Department of Children's Services in Tennessee in support of their efforts to decrease seclusion and restraint and better monitor the use of psychotropic medications for children in care. He co-authored the practice parameter on the prevention and management of aggressive behavior in child and adolescent psychiatric institutions with special reference to seclusion and restraint for the American Academy of Child and Adolescent Psychiatry. Dr. Balanci is a member of ACAP's work group on quality issues, which is responsible for writing the practice parameters that define the standards of care for the field of child psychiatry. In 2008, he provided testimony to the U.S. House of Representatives Committee on Education and Labor regarding unlicensed and unregulated boot camps and wilderness programs, as well as the House Ways and Means Subcommittee on Income Security and Family Support regarding the increasing use of psychotropic medications for children in the child welfare system. Dr. Molly Finnerty is a board-certified psychiatrist and the director of the Bureau of Psychiatric Services and Clinical Knowledge Enhancement Systems, also known as Psyches, for the New York State Office of Mental Health. In that capacity, Dr. Finnerty directs the development, implementation, and evaluation of web-based tools to improve the quality, safety, and efficiency of behavioral health care in New York State, with a focus on psychotropic prescribing practices. Psyches Medicaid is a HIPAA-compliant, web-based application that aggregates administrative data into user-friendly reports to support clinical decision-making and quality of care. Psyches is implemented in over 400 different settings across New York State and has yielded significant changes in quality measures and a return on investment in pharmacy cost savings. Dr. Finnerty is a graduate of Middlebury College and received her medical degree from the University of Illinois at Chicago College of Medicine. She completed her psychiatric residency at Columbia University, New York Presbyterian Hospital, and has completed fellowships in public psychiatric and services research. She is affiliated with NYU Medical Center and is a research associate professor in the Department of Child and Adolescent Psychiatry. We are happy to have both Drs. Balanci and Finnerty with us, and now I will turn it over to our first presenter, Dr. Balanci.
Thank you, Jessica and Kamala and Center for Healthcare Strategies. I'm really delighted to be able to talk with all of you today about a topic that I have great interest and passion about. And my job this afternoon is just to create the context for the conversation about psychotropic medication. Why are we so concerned about a need for oversight and monitoring, particularly for children who are in the child welfare system who are being prescribed these medications. If I can have the first slide. In part because there's been an exponential increase in the utilization of these medications in children and adolescents, not just in the child welfare system, but in the general population. There were times in my training in the 1980s and early 1990s where we really were just using stimulants and, on occasion, Mellaril or Thorazine for extreme conditions. And now we're pretty much using any psychiatric medication that comes on the market is pretty quickly being explored for utilization within children, even if that medication hasn't been tested for safety or efficacy for the diagnosis that we're using it for or for the population that we're using it on. The first slide looks at some of the psychiatric medication utilization data we have for the child welfare system. And you'll see in that first bullet that there's a broad range of utilization rates, anywhere from a low of 13% within a state's child welfare system up to a high as much as 50% of one state's child welfare system is being prescribed at least one psychotropic medication. And I'll use psychotropic medication and psychoactive medication or psychiatric medication interchangeably. It's really any medication that's being used for a behavioral health reason. When you look at antipsychotic use, which is one class of psychiatric medication, the rates are even more variable, from a low of 2.8% in Hawaii to a high of almost 22% in Texas. And the range going from, or the rates going from almost 8.9% in 2002, increasing to 11.8% in 2007. So we've seen a steady increase in the utilization of really all psychiatric medications, but particularly within the class of antipsychotic medication, we've seen a significant increase. We focus on antipsychotics particularly in part because they carry a high potential side effect burden, particularly in children. When these medications, particularly the second generation antipsychotic medications, these are medications like Risperdal, Zyprexa, Seroquel, generic names of quetiapine, olanzapine, risperidone. When they were first brought to market, we knew that in adult studies there was, anywhere from a 5 or 6 pound weight gain associated with these medications. When we started using them in children, we started seeing much more significant weight gain. And now we've got worries and concerns about the potential risk for obesity. Well, we know that there's a risk for obesity, but potential risk for diabetes and metabolic syndrome and heart disease. And the rates of metabolic monitoring are quite inadequate at the present time. In most studies, they're under 20% in the adult population. So we're exposing kids to these medications with potential significant side effects at ever-increasing rates. And this has generated some questions and concerns, both within the field of child psychiatry, where there's a rich debate about the efficacy of these medications and the appropriate use of these medications. When are they warranted? Who are they warranted for? What should we be seeing in terms of side effects? What else can we be doing in place of these medications? But it's also generated a lot of discussion at the federal government level, at policy levels, and increasingly in the fields of child welfare, who are often felt to not have the sufficient tools to respond to the question of whether or not a child is being appropriately medicated with these medications. And that's really what led to this whole Psychotropic Medication Quality Improvement Collaborative, to try to get at the question of what would best practice look like in responding to some of these concerns. Next slide. This is additional data from the state of Texas, which has one of the highest utilization rates. Of interest is that in recent years they're showing a decline both in their antipsychotic medication use and their overall psychiatric medication use. This data is from a study from 2004, so it is old data. At the time, Julie Zito looked at a cohort of 32,000 children who were in foster care at the time. 38% were being prescribed a psychiatric medication. 41% of that group were receiving 3 or more medications simultaneously or concomitantly. And when you break it down by age group, you see that 12.4% of the 0 to 5-year-olds were being prescribed a psychiatric medication. I apologize, 2005 prevalence data. 55% in the 6 to 12-year-old group, and 2/3 of the 13 to 7-year-olds were being prescribed a psychiatric medication. The next slide. When Julie Zito was presenting before Congress with me and was presenting this data, her response to Congress is when, 2/3 of adolescents in a state's child welfare system are being prescribed a psychiatric medication, you better have a good assurance that the medications are warranted. And that's the challenge, I think, facing most child welfare systems. How do you ensure that the medications that, as the local parentis, as the responsible authority giving consent for these medications, how do you know that these medications are being appropriately prescribed, appropriately warranted, and not being used of other less invasive interventions such as a psychosocial intervention? I say less invasive because I think the side effect profile of a psychosocial intervention is less than what we're seeing with some of the antipsychotic medications. This led to the federal government issuing a joint memorandum in April of 2012 from the federal child welfare system, ACYF, the federal Medicaid and Medicare system, CMS, and the federal mental health system, SAMHSA. In this memorandum, they defined the issues surrounding psychotropic medication use. They highlighted available resources for states from the federal government, and they encouraged increasing access to clinically appropriate screening, assessment, evidence-based interventions for foster children with mental health and trauma-related needs. And I'd highlight several other information memorandums on each of those topics that they have promulgated since this time, with really nice summaries and resources, so I'd refer you to those resources. The next slide. The federal government passed Public Law 110-351 in 2008, the Fostering Connections to Success in Increasing Adoptions Act of 2008. In that law, states were required to develop a plan for oversight and coordination of health care services for children in foster care, in coordination and consultation with Medicaid. Pediatricians and other experts in health care, as well as experts in the recipients of child welfare services. And ensure that children in foster care receive high-quality, coordinated health care services with appropriate oversight of any needed prescription medicines. So this was actually the hearing that Julie Zito and myself and my colleague here at Tufts Medical Center, Laurel Leslie, were testifying in support of. It did also open up some resources for kinship care, and a number of other good things came out of this bill. But there was that one line that began to increase the federal government's expectation that states have appropriate oversight of prescription medications. There was no consequence, there was no requirement that came out of that law when the regulations were written. But that changed with the next law. The next slide. So the Child and Family Services Improvement and Innovation Act did then specify that healthcare oversight plans have to include an outline of protocols for the appropriate use and monitoring of psychotropic medications. And it established a statutory requirement that oversight of psychotropic medications be explicitly addressed in a state's healthcare oversight and coordination plan. And this is the first time the federal government actually required that as a condition of participation in the federal child welfare system. Those first performance plans were required last June, and there was a meeting hosted by ACYF, CMS, and SAMHSA last August in DC called Because Minds Matter, which was a technical assistance offering in support of the state plans that were being developed. Next slide. Factors influencing patterns of psychotropic medication use, as stated in the informational memorandum, included insufficient state oversight and monitoring, the gaps that I think many of us know exist in coordination and continuity of medical and mental health care across both public health and social service systems, provider shortages. There's very few licensed child psychiatrists in the country, roughly about 7,000 practicing child psychiatrists, with the Surgeon General estimating we need about 30,000. And lack of access to effective non-pharmacological treatments in outpatient settings. Not that there are no non-pharmacological treatments showing evidence-based practices. It's trying to access clinicians who are actually trained in those evidence-based practices, like trauma-focused cognitive behavioral therapy, and willing to see patients for Medicaid reimbursement rates. Next slide. They really promoted the use of clinical guidelines, and this is something that we also heard from states in our TUS study, where we surveyed state child welfare systems asking what their needs were, what their level of concern was about the issue of psychotropic medication. And consistently we were hearing from states that as a child welfare system, often without medical consultative resources within the child welfare system or available outside of the child welfare system, they felt inadequate to be able to answer the question about appropriate use. And the struggle with appropriate use for me is that often the answer is on a case-by-case basis. I think there are ways to set up red flags, and we can talk a little bit about that during this webinar, such as certain age cutoffs, certain number of medications that would trigger some kind of a clinical review, being on 2 medications of the same class, dosages that exceed FDA guidelines if they exist for children, et cetera, that could trigger a targeted review. But that would still require some kind of medical ability to have a consultation with the prescriber about what their rationale is for using those medications. And so states were really looking to professional societies like the American Academy of Child and Adolescent Psychiatry or the American Academy of Pediatrics to help guide them in what is a reasonable approach to the clinical needs of children within the child welfare system. So comprehensive, coordinated screening, assessment, and treatment planning mechanisms that identify children's mental health and trauma treatment needs, evidence-based assessments, informed and shared decision-making and methods for ongoing communication. These are all the core components of clinical guidelines that support best practice. Effective medication monitoring at both the client and agency level, availability of mental health expertise and consultation regarding both consent and monitoring, and mechanisms for accessing and sharing accurate and up-to-date information and educational materials related to mental health and trauma-related interventions. So that would be for the foster parents, for the child welfare workforce, for the biological parents, and for the youth themselves. Next slide. So within our Psychotropic Medication Quality Improvement Collaborative, that's what PMQIC means, we had various state approaches. Some states were looking to develop or revise their informed consent procedures. We had 2 states that had no active informed consent process. Essentially, if a child psychiatrist or a primary care doc ordered a medication, then the foster parent, whoever brought the child to the visit, would go fill up that prescription at the local CVS or pharmacy, and the child would start taking the medication. There was no process where the state actually formally gave consent to the psychotropic medication being prescribed. We had other states that had a much more rigorous consent process that included outside university consultation to the child welfare system, basically green-lighting the appropriateness of the medication request, and then the state giving the consent. Develop method for generating real-time medication utilization data, in some cases from Medicaid claims. This is kind of the holy grail of our work. If we can actually get to a place where there is some kind of in-house medical consultation available to the state child welfare system, it could be embedded within the state child welfare system, it could be in a consultation to a university medical center, it could be some amalgam of the two, it could be borrowed resources from the mental health department. However you construct it, increasingly I think there's a recognition that some kind of a mental health or medical consultation to the child welfare system about appropriate use of psychotropic medications is becoming increasingly needed. And in order to drive some of the utilization of that precious resource, being able to identify some of the higher risk cohort of children who are taking these medications would lead to greater efficiency in the utilization of those reviews. You know, frankly, I'm not that worried about stimulant medication for children. I think that you want to watch the dosing of it. You want to make sure that it's, you know, consistent with a diagnosis of ADHD, that it's not being diverted for abuse, and that's a particular concern in some of our families where substance abuse is an ongoing concern. But I'm more concerned about the medications like the antipsychotics, which carry a heavy side effect profile, and we may be exposing these children to lifetime physical health problems. And so by using real-time data, we can then queue up some of the cases that trigger some kind of a red flag for review. And that leads to the red flags. As I mentioned, you can set up any number of red flags. We talked about, and in our psychotropic medication quality improvement states, they're looking at age, typically under age 6, dose. If there are FDA dose guidelines, we use those. Often those don't exist for children because these medications weren't specifically marketed to children but are being used in children. But adult dose guidelines, if they exist, are a reasonable place to start. Duration. So a number of states are concerned about children who are placed on medication in an inpatient setting, go into an outpatient setting or a foster home setting and are seeing an outpatient provider, and the outpatient provider is reluctant to take the child off the medication for fear of disrupting the placement or disabling or causing some kind of behavioral or emotional regression in the child. And so we also want to see whether or not episodically people are reassessing the need for the medication, typically on an annual or semi-annual basis, depending on the medication and the reason for the medication. Diagnosis. Does the medication being prescribed match the diagnosis on record? One of the interesting things in some of the research being done by a colleague, Dave Rubin, in Philadelphia, Children's Hospital, Philadelphia, he's looking at antipsychotic medication use, not just in the child welfare system, but in a very large national Medicaid data set. And the number one diagnosis for the atypical antipsychotics in his data set is attention deficit hyperactivity disorder, with no comorbid mood disorder or bipolar disorder or psychotic disorder. You know, and frankly, as a child psychiatrist, I scratch my head when I look at that. It doesn't make sense to me why a child with ADHD is being prescribed an antipsychotic medication. And so this is another red flag that can be caught. Now, maybe there is a reasonable explanation, you know, and the red flags are not meant to be a gotcha with the prescribing community. I am also a prescribing child psychiatrist and actually would welcome a dialogue with my state agency with whom I serve their children about why I might have children on medication regimens that are atypical or at odds with any red flags that they set up. And I think that that can be a very useful and productive process. In some of the states where they are engaging in some of these physician reviews, they tend to actually be a relatively collaborative process. I think some states are concerned that providers will become very reluctant to serve the children in the child welfare system if their medical opinions are being seen as being questioned or suspect. You can also look at classes of medications and worried about polypharmacy within a class, or what we called co-pharmacy, being on more than one atypical antipsychotic medication or being on more than one antidepressant at a time. Now, sometimes there's a good reason for that. Sometimes we use an antidepressant like trazodone for sleep and a different antidepressant like Prozac for anxiety or depression. And so it's not that, you know, because a red flag is triggered, that means the doc is doing something wrong, but it could imply some practice concerns that at least are warranting a review or conversation or consultation. States also have developed oversight and monitoring processes that are most appropriate for their jurisdiction and practice concerns. So they really looked at what are the issues that they're most concerned about, what makes sense within their jurisdiction, and we have a host of states, as Kamala mentioned, both large and small, East and West Coast. Next slide. So we convened the data subgroup after the states identified what were the core goals of their 3-year Quality Improvement Collaborative, what were they looking to achieve. And as they identified their goals, we then needed to identify what was the data that was going to support the outcomes measurement on their goals. And then we also developed common measures that all 6 states would be measuring over the course of the 3-year collaborative. And then we needed to define our terms if they were going to be able to import actual data that was meaningful and reliable, with the goal that we're looking at the same data meaning the same thing across all 6 states. One of the things, having done both policy work and research and clinical work in this area, that's been confounding for me is when you look at data, you really have to dig beneath the data to understand what are they measuring, how are they defining their terms. In Dr. Rubin's research, he only looks at antipsychotic medication use within 3 to 18-year-olds. Other states measure it from 0 to 18. Well, that's going to seriously impact your overall percentage utilization. So we're trying to come up with some common definitions around how we're going to determine this data. One of the other things that I found is that many researchers consider polypharmacy not the total number of medications, psychiatric medications the child's being prescribed, but how many medication classes the child is being prescribed, which doesn't make any sense to me. I think that's then an underreporting of actually what the child is taking. So just to clarify, if a child is on 2 antipsychotic medications simultaneously, Risperdal and Seroquel, for instance, as well as an antidepressant like Prozac, and maybe Trazodone for sleep, which are both in the antidepressant class. If you just measure those 4 medications by class, it would be reported out as 2 versus the actual 4 medications that the child is taking. And the reason I think that's a significant difference is that 4 medications are going to carry cumulative side effects that if you're just thinking they're on 2, may not raise the same level of concern. Also, there's very little evidence for a child or an adult taking 2 antipsychotic medications simultaneously. There's a little bit more evidence that, depending on the target for the medication, 2 antidepressants might be indicated, as I stated earlier. So the goal was to identify and agree upon common definitions and measures that each state could implement to address the inappropriate use of psychotropic medication. Next slide. So these were the definitions that we landed on for the purpose of our Psychotropic Medication Quality Improvement Collaborative. Foster youth is any child placed away from the parents or guardians in 24-hour substitute care and for whom the state agency has placement and care responsibility. And this was the federal definition. Whenever a pre-existing definition existed that we could adopt for our purposes, we went with that. Some of that we actually borrowed from Molly Finnerty's work with Psyches, and she can tell you more about that next. Young children, we decided the cutoff was age under 6, and consent would have to be defined by the individual state laws or regulations if they existed. Next slide. Psychotropic medications, as I said in the introduction, are medications being used for an emotional or behavioral condition. And this was important because some of the medications that we use in psychiatry are actually originally medications that were brought to market for other purposes or indications. So we use blood pressure medications like clonidine or 10X for impulsivity and ADHD. We use medications like seizure medications, Depakote, Tegretol, for indications like mood stabilization. So you need to know what's the indication, not necessarily what the medication is, in order to know whether it's classified as a psychotropic medication. And that can be a little tricky. Medications that are automatically assumed to be a psychiatric indication are medications that have no other indication other than a psychiatric or behavioral health one, such as antipsychotic medications, stimulants, antidepressants, benzodiazepines or medications like Valium, anti-anxiety medications, including Buspar. Those would also be medications like Xanax or Ativan, and then mood stabilizers, including lithium. So if a child was on any of these medications, we automatically identified that as a psychotropic medication. Next slide. Medications used for a psychiatric purpose but not typically classified as a psychiatric medication would require cross-referencing with their diagnosis in the Medicaid system. So this is getting a little bit trickier now. The alpha agonists that I talked about, clonidine and guanfacine, and their long-term analogs, Intuniv and Capvey, use of these medications could be for hypertension or high blood pressure in children, but it was so rare that we felt it was safe to assume that they were being used for a behavioral indication. Anticonvulsants, if in the absence of a seizure disorder diagnosis, were also assumed to have a mood stabilization. So this would require the ability to look into the Medicaid record or the clinical record, the Psyches system, see if the child had a diagnosed seizure disorder. If they did, then the anticonvulsant medication was not classified as a psychotropic medication use. If there was no evidence of a seizure disorder, then it counted as a psychotropic medication indication. Next slide. Polypharmacy was more straightforward. We're actually measuring 2 or more, 3 or more, and 4 or more psychotropic medications. And they would need to be on the medication for 90 days consistently in order to be counted as polypharmacy. So just to clarify, sometimes in psychiatric practice, we will go from one medication to another, and during a period of time there may be overlap while we're decreasing the dose of one and starting the dose of the second. And so we allowed for up to 90 days of a cross-taper of the medication, which in clinical practice is pretty generous. I would rarely take more than 4 to 6 weeks to do a cross-taper in order to not overcount medications that were in the process of being discontinued while a new medication was being started. So that's the rationale for having that 90-day requirement. But if they continue on 2 medications beyond 90 days, then that was counted as polypharmacy, or in the case of 2 medications from the same class, co-pharmacy. Next slide. So dosage guidelines. If there was an FDA approval for the use in a pediatric population, we went with that. If there were multiple indications in youth, we used the maximum dose for the psychiatric indication. So we tried to be generous and not have an overly restrictive floor around dosage guidelines. If there was no FDA indication for the pediatric population, then we would look at a report generated by Texas around dosage guidelines for children within their foster care system. And we have the reference that you can find that. And then no FDA indication or guidance from the Texas report, we then resorted to a textbook on pediatric psychopharmacology. And when all else failed, we would use the adult PDR, Physician's Desk Reference Maximum Dose Guideline. And this was all adopted by good work that Molly and her team did in the Psyches system in New York. Next slide. And then for metabolic monitoring, we focus specifically on the antipsychotics. There are certainly some states that are looking at monitoring for metabolic conditions secondary to other psychiatric medication classes. But for our work, we were focused specifically on the antipsychotic medication. And there again, there was good work that had been done previously by the American Diabetic Association and the American Psychiatric Association. These were adult consensus guidelines. But we felt like they were appropriate to be adapted for our purposes, with the exception that we were checking lipids annually rather than every 5 years as the guidelines indicated. States were free to set their own protocols requiring more frequent measures, but this list was considered to be the minimum standard. And states also, as I mentioned, were monitoring other metabolic parameters or other labs that require blood level monitoring. Next slide. Minimum metabolic monitoring protocol for the second-generation antipsychotics, that's what SGA stands for. Personal and family history, both baseline and annually, should be asked. Waist circumference should be checked baseline and annually. Weight and BMI, body mass index, should be checked at baseline every 4 weeks up to 12 weeks and then quarterly. Blood pressure checked baseline at 12 weeks and annually. And then a fasting plasma glucose at baseline 12 weeks and annually, and a fasting lipid profile baseline 12 weeks and annually. And those, again, were from the ADA, APA draft guidelines. Next slide. And this is an example of how Illinois is monitoring the metabolic parameters associated with it. I'm not going to go through all the details of it, but you can see how they've got along the left-hand column what they're measuring, what the risk criteria are, so kind of what the baseline measures are that would trigger some kind of an alert. So when the measure being tested is abnormal, and then when these examples are supposed to be established. Based on the shadowing tells you what the frequency is. The next slide. And those are some of the just follow-up details. Next slide. So the common measures, these are the measures that all 6 states have agreed upon, and they were pretty ambitious. They came up with a set of 8 measures in total, most of them quantitative and 2 qualitative. They're going to measure the percentage of children in foster care on any psychotropic medication, on specific classes of medications, on more than one medication from the same class, so for instance 2 antipsychotic medications, on 2, 3, or 4 plus psychotropic medications, they're measuring each of those, under 6 years old on any psychotropic medication, and under 6 years old on 2, 3, or 4 plus psychotropic medications, under 6 years old on antipsychotics. Next slide. And then the qualitative measures are implementation of evidence-based or promising interventions for sleep disorders and/or aggression, and development of an informed consent process, or increased adherence to the state's informed consent process. Next slide. And just to be clear, this is not an intervention that's just focused on getting kids on less medication. We're not even sure that that's ultimately going to be the outcome. Our overall goal is providing children with better mental health resources, particularly this cohort of children who are in foster care who we know are exposed to trauma, substance abuse in utero and substance exposure post-utero, neglect at critical stages of development. They have lots of reasons for having significantly high rates of emotional behavioral disorders. You know, most studies say anywhere from 50 to 85% of children in the child welfare system meet criteria for a psychiatric condition, behavioral health condition, developmental condition. So, you know, some people look at that statistic and say, well, maybe we're actually under-medicating this population. And the only way we can really know the answer to that is by doing these kind of careful reviews, which I think this whole process and project is in support of achieving. And we're hoping that any lessons learned we'll be able to share with the larger community by collecting the data that we've defined. I'm going to stop there and turn it over to Molly unless there were any specific questions.
Christopher, it's Jessica. Just one quick question. For the states that are already measuring some of the measures that you discussed or even other items, is it the expectation that those states would change their measures to align with the consensus definitions?
Within the Psychotropic Medication Improvement Collaborative?
No, just in general, any state participating.
Well, I think it's always hard to give up data that you've already developed and defined a certain way because then you have to put a big asterisk when you suddenly start seeing different rates, either up or down, and have to explain that. You know, what I was surprised, frankly, was that we were able to come, at least with the 6 states we were working with, to share definitions as quickly and easily as we were able to. So nobody actually had to give up definitions or data that they were already getting. Some of this, I think, is fairly intuitive and not terribly controversial. So maybe that was the rationale. But I'd say for the states that aren't part of the collaborative, to take a look at how wed you are to your current definitions and the data that that's generated. Because I think it would be nice if we could get to a national standard, which was not the goal of our work, although it would be a desired and favorable outcome if we could, both research, policy, and practice side, agree on what are the terms that we're going to use so that we can look across states, across counties, within states, to try to identify where practice seems to be at odds with other parts of the state or other states, to try to understand what's going on there, whether that represents better care for the children or worse care or different needs that might be addressed as a result of good, reliable data.
Great. Thank you, Dr. Balanci, for your informative presentation. We're now going to turn it over to Dr. Finnerty.
Hello. Pleasure to be talking with people today. I'm going to be focusing on how states can use their data to improve clinical care. I'm going to talk a little bit about what is Psyches. It's our Psychiatric Services and Clinical Knowledge Enhancement Systems, and just a few screenshots from that to give you a sense of what the application does. Share with you some of the implementations that we've conducted over the last decade and the lessons learned, and then just talk briefly about another initiative with the Agency for Healthcare Research and Quality, CMS-funded collaborative to develop measures for youth. So part of what we're talking about is how states can use this tremendous resource that they have, which is their Medicaid data, either fee-for-service or encounter data, to help support clinical care and drive quality and lower costs. So Psyches is an example of a web-based application that aggregates this large volume of Medicaid data available to the state into user-friendly reports. So it's a profile of secure, HIPAA-compliant web-based applications that make administrative data, like Medicaid data, available to support clinical decision-making, quality improvement, planning and oversight for state health agencies, and shared decision-making. We have a new client version that we've recently released. So to date, we have 3 different applications that we support. One is for our network of state-operated hospitals and clinics, and it's been implemented throughout that system. But more recently, beginning 2008, the Psyches Medicaid, which runs off of our Medicaid database, is implemented in 400 programs. And finally, the consumer version, My Psyches, we have 2 pilots and are in the process of expanding to 15. So the goals of Psyches for administrators in state agencies and in counties is to help support driveline-given cost-conscious quality improvement and to support data-driven policymaking so that policy decisions can be based on data. For physicians and supervisors, it gives them access to a tool that can both see how they're performing on measures, but also at the point of service provides access to individual client data to support clinical decision-making. And then for recipients and family members, the consumer version provides complete medication histories as a tool to support treatment or when presenting to a new provider to explain your medication and treatment history. This application also allows patients to report their own outcomes and to participate in a shared decision-making process with their physician. The content of Psyches includes a series of quality reports, individual client clinical summaries, as well as reports designed to highlight regional variation through maps and statewide profiles, And it also has a search function that allows you to identify groups of clients or individual patients. Next slide. The current indicator sets in Psyches relate both to psychotropic medications, and you can see the sets that are listed here. Within each of the sets, there could be up to 8 different indicators within that. So one is dedicated to polypharmacy, either overall psychotropic polypharmacy or within particular classes, for example, antipsychotic polypharmacy. The cardiometabolic looks at interactions between a choice of an antipsychotic and an existing condition, for example, such as diabetes, where folks might be at increased risk for worsening of their condition. High doses of psychotropics, and then a use set that pulls from each of these, but is really designed to focus attention on youth, including high doses of psychotropics in youth, polypharmacy in youth, and then use in children less than 6 years of age. But we also have other types of measures, including examining hospital-related high utilization, readmissions, preventable hospitalizations. These are medically related admissions where good outpatient care might have prevented a medical hospitalization. We also look at health promotion, things like whether people have had their annual physical or whether they've had appropriate diabetes monitoring or screening for individuals on antipsychotics. And we also have one looking at behavioral care coordination that includes measures related to adherence to medications, as well as high utilization of emergency and other hospital services related to behavioral health causes. Next slide. So the goal of Psyches is to take this sort of large volumes of Medicaid data and turn it into something that can be useful. So you start out with, this raw ingredient of lots of data, and how can you put that together in a way that creates useful information and present it in a way that's user-friendly, that makes people want to use it so that they can learn from that and apply it in their work. Log on to Psyches through using a token. It's a secure log-on site. And the home page that you get to after logging in shows in the next slide a quality indicator overview of how your individual clinic looks. Whatever your treatment setting is, when you log in, what you see is how your particular agency looks or clinic looks, and it shows you all of the indicators, how you're performing on them relative to regional comparisons and statewide comparisons. You can filter these for people that you feel are more similar to you, for example, by age or by treatment setting, if that's important to you. But you can drill down, as on the youth indicator here highlighted just for an example. In the next slide, you can see that each of these you can drill down and see how you're performing on the indicators within that particular set. And again, see how you're performing relative to others. Each of these reports is linked to a list of clients on your own caseload that have this quality flag that can support a clinical review. So it's not just that you're seeing your performance, but you can understand how it's being driven. Who are the clients that have this flag, and can I do a clinical review to see if there's anything that is warranted in terms of a change in treatment. In the next slide, you can see some of the content that we include in these clinical summaries for individual patients. So as you drill down from a quality indicator to this list of Medicaid enrollees that have this quality flag, and then finally to the clinical summary, what that clinical summary offers you is up to 5 years of treatment history for all their mental health as well as physical health services that have been paid for by Medicaid, either through encounter data, this is managed care, or fee-for-service in any setting over time. And we try to organize it as best we can so that it looks like a medical record, so that it would have the same kind of flow and format. So in the next slide, you can see the way that it's organized, where you start out at the top with the client's name. This is an actual client, however, the names have been scrambled to preserve identity. What you can see on the very top here is there's something that allows you to select how much data you would like to see, and this is set for up to 5 years, the date the report is run, and whether you want to see the enhanced protected health information. So this allows you to toggle back and forth in case you had to share a particular report with someone that you didn't want to show all of the enhanced PHI, including HIV status, substance use treatment, genetic disorders, or family planning, things like abortions or childbirth. Kids' names, date of birth, their age is calculated, and what their Medicaid eligibility is, and whether they're enrolled in any managed care program currently, and whether they hit criteria for any of the quality flags that we've developed to date, and which ones and why that might be. So, for example, in the highlighted box here, this is someone who hits criteria for polypharmacy, and it shows you why, that they're on 2 different antipsychotics. All of the behavioral diagnoses that have been billed are showed in a chronological order, with the most recent coming up first. In the next slide, you can see one of the ways that we try to aggregate data. So this would be several years of data, and if we had 5 years of data here, that would also show up. And it allows you to sort of observe the pattern of services. The dark bar across the top lets us know that this individual has had relatively continuous Medicaid eligibility during this period. But we can see that there's been sort of spotty pickup of medications over time, and that they're sort of a different clustering, both for their behavioral health meds as well as their medical meds. Under that, you can see inpatient behavioral services, and there's been some episodes of that for this child, as well as use of emergency services, both for medical and behavioral health cause. We can see the pattern of outpatient services that the individual received to get a sense of engagement. So each of those points, if you'd hover over it, it would give you the exact date and location of that service, but it gives you a sense of what's the pattern of services and how those patterns seem to relate to outcomes like hospitalization and ER use. Next slide. For each of those types of services, for example, medications, there's a table that summarizes the medications received. And rather than show you each sort of prescription filled, it gives you sort of a medication trial where the first time it was picked up, the most recent time the prescription was filled, the most recent prescriber, and the most recent dose calculates the duration for you in time. But if you wanted to drill down and see the detail of each pickup and the pharmacy where it was picked up, and more details about the prescription itself, that's also available. In the next slide would give you an example of how we aggregate the inpatient and emergency room data, flagging whether it was an emergency or an actual inpatient stay, whether it was for medical cause or behavioral health cause, the location of that service and the length of stay in the hospital, the diagnosis given at that time. And the next slide shows you a different kind of capacity where you might be looking for a cohort of individuals or maybe just one individual. So, for example, if someone presents to an emergency room, you may need to find one particular person and could enter their Medicaid ID or Social Security number to find them. But you can also find groups of people. So let's say you were interested in doing an intervention for children who happen to be on psychotropic polypharmacy or multiple antipsychotics. For a provider, they could do this, and the search would yield back for them only those on their caseload. So if I'm in a provider agency in the community, it would only give me back the children that I'm personally responsible for. Next slide. This shows a kind of a statewide reporting function that would allow you to sort the entire state by how people are performing on a particular measure of interest. So in this case, it's highlighted for prescribers, and this would be more something that, say, a state-level agency might be interested in. On any one of these reports, I could filter for a particular age group or a fee-for-service or managed care type of population, but see who are the prescribers that, you know, if I sort my entire state, who pops up to the top of my list. And these types of flags are refreshed monthly. Next slide. So I'm going to share a little bit about how we've used this tool, both to support clinical work and quality improvement. In the next slide shows a list of the different clinical implementations. We have shared this most recently with our behavioral health organizations, kind of a precursor to managed care for behavioral health in our state. They use it when they're called from a hospital about a client coming in, and the role that they've been given by our state is to help coordinate better discharges. So being able to assess the full history and level of engagement someone has had in the past in different service settings has been helpful for them to assess, really get a sense of who this person is and to think planfully about how to prevent additional readmissions. But we've also released it in an implementation and have it in 101 of our hospitals to date, the notion being that hospitals should have access to this tool first before behavioral health organizations got it, that really the treating clinician is the one who needs this most. We've done emergency room implementations and currently put that in 15 of our emergency rooms. And here you can see the use where in emergency rooms people are most in a crisis, maybe least able to share with you their history, and at the same time is not someone you may be familiar with. And so having a sense of what kinds of treatments you've gotten, how well that's been going, where you've been engaged or not in the past can be helpful for that evaluation and may actually prevent admissions. Assertive community treatment, one of the highest level of outpatient services that we offer in our state. We have 41 teams implemented, and case management and health homes, 116 teams. In the next slide, I'm going to talk a little bit about, what tools that are available for these kinds of purposes, and, probably is obvious, but access to psychiatric records, even by non-psychiatrists, can decrease readmission rates and can improve the quality of care. And that the characteristics of these kind of health information technology tools that have seen positive clinical outcomes have certain attributes that include this ability to do this kind of reporting that will allow you to work with a population that you have responsibility for. And for individual clinicians, computerized prompts or links to EMRs can really help make that more user-friendly. In the next slide, I'm going to show you some of the quality improvement projects that we've used this for. So in a clinical project, the real goal is to say, here's better and more comprehensive clinical information that then may be available to you. For the quality improvement projects, the focus is more on working together with a number of provider agencies to move a particular indicator or one or more in a collaborative way, to say, can we all work together to see if we can move some of these measures. In their state PCs was our very first project in 2004, where we first implemented with a focus of reducing antipsychotic polypharmacy. We've also had a series of phases in our large state CQI initiatives with our mental health clinics, and have 320 clinics participating in those, and have had 3 phases to date. And we've had also a series of hospital quality collaboratives, and it's nice. I think that particularly in the hospitals, it's a purely voluntary, no incentive, no incentive at all, except for the access to data and being able to work collaboratively together to improve care. And so it's been gratifying, at least, to see that people would like to see more phases, right, that they want to continue to work together in this way. In the next slide, some of the benefits and uses of Medicaid data to support quality improvement include that, a large number of quality measures can be assessed directly from Medicaid data. And although there's a lot of interest in developing EMR-based measures, and that's certainly an area of active focus for measure development, the nice thing about the Medicaid measures at this point in time is that really almost all states can do them, that they don't require chart review, that you can get your entire Medicaid population, data extraction or data entry is required, and that it allows for creation of tools that can promote this transparency, that all stakeholders with access to data can calculate it and get the same kinds of information, and you can share the same kinds of information across sites. And that these tools can also be meaningful and actionable, that if the data is available to the state in nearly real time or, with a little bit of a lag, that this can help to identify problems and address them clinically in a clinically meaningful time frame. For our Psyches quality improvement initiatives, I want to focus on three particular projects that I was going to share a little bit with you about some of our lessons learned. And one was that first antipsychotic polypharmacy project in our state psychiatric hospitals. A second was our hospital collaborative focusing on cardiometabolic issues. And the third was our statewide project with mental health clinics in phase 1, looking at polypharmacy and, again, the cardiometabolic indicator. So in the first state project, we looked at, maybe next slide, we had 4 phases of sort of interventions. And in the first one, we just implemented Psyches, and I was really rooting for the fact that if people had this better data, it would just all by itself change practice. Then in phase 2, the medical director launched an initiative where he said that if you're going to start polypharmacy in the hospitals that he had oversight for, that you would have to ask for his approval. But this policy was not enforced at the pharmacy, which meant that psychiatrists could keep prescribing medications. And then in phase 3, they added feedback. So they said, well, although we're not forcing this at the level of pharmacy, we are monitoring whether you're observing our policy, and we're going to give feedback to the hospital director whether you are or you aren't, and ask you to, improve on that. And then in the fourth phase, there was a switch of medical directors, and that policy was ended, and hospitals were asked to just institute their own practices to either continue or sustain this or not. And you can see in the next slide what each of those strategies yielded. So in the first, just implementation of Psyches, all by itself really didn't seem to do anything. You see that's that sort of lead-in phase where it's pretty much flat or even a little bit up. The introduction of the policy in just a few months promoted a rapid decrease, and that was just, the medical director of this hospital system says, we're watching this, we have a new policy, you have to ask me first before you begin antipsychotic polypharmacy. Rapid drop. But then you see a little plateau, and he didn't like that, so he said, okay, well, let's try harder. We're going to actually give feedback to our hospitals about whether they're complying with my policy. And then you see a more sustained continued decrease, really driving those rates down. And what you see is that there's a sustaining of that impact even after those requirements go away. So that somehow things were changed in such a way that even when the policies were removed, what you see is that the impact is sustained. And the next slide sort of summarizes those points, that access to the information alone did not change practice, but that policies can have a very significant impact on prescribing, even when they're not monitored, but more so when they are, and that impact can persist even after policies end. And from a funding perspective, having this project kind of success under our belt was actually used as the rationale to fund expansion to the Medicaid program. In the next slide, I'm going to talk a little bit about the cardiometabolic project that we had with our hospitals. In this case, access to the Medicaid data for their own clients, it's only for their own clients, but through Psyches was a big incentive for participation. Also partnering with the hospital association. Things just sound very different coming from the hospital association where they have this long-time relationship. There's a trust and a camaraderie there working with the hospital association that just worked very nicely for a collaborative. And then we had monthly collaborative calls, and we would share impact. And so on our part, we would run Medicaid data on the impact. Of course, they had their own access, but they couldn't maybe see how the other hospitals were doing, so we would share that with them. And clinics would share their challenges and strategies with each other. And in the next slide, you can see what the results were. And this was after 9 months. There's some hospitals that actually increased and had higher rates kind of in the wrong direction, but those were not significant increases. Some that had small decreases, also not significant. But overall, there was a significant change across all of the hospitals, and the top 5 hospitals, those were significant changes there just 9 months after launching the program. And in the next slide, we were sort of interested to see that two things here. One was that it was easier to decrease new starts, to stop a person from starting an antipsychotic that might have been a problem. So in this case, we're trying to decrease the start of an antipsychotic with a higher metabolic impact in a person that already has a risk, like they have obesity, diabetes, some other thing that makes us think, let's not burden this person medically further if we have a treatment alternative. So interesting that and not surprising, it's easier to stop a new start than it is to change an existing regimen, but also that there's a lot of off-label use here, and I know we talk about it certainly for children, but it's true for adults as well, and that it was easier to stop those new starts when it was an off-label use, right? So if it's already not completely clear that this is your only treatment option, easier there to intervene. And you can see we really had a big change, that sort of 72% down on the new starts for the non-psychotic conditions. And the next slide sort of summarizes some of those points. So easier to decrease new starts than to change existing regimens, easier to decrease particularly for off-label use, but also to share that small interventions, so some of those high-performing hospitals that made a big difference, it was small interventions that moved some of them. For example, a medical director who would send an email directly to the staff with a list of their particular clients and say, you know, we're doing this project. I'd like you to take a look at these clients and see if you can get them off. You know, that was the whole intervention. And he did very well. Other hospitals instituted within their own setting, it's not that it was coming from the state, within their own setting, their own kind of internal prior approval by a medical director type. And lastly, I was going to talk about the mental health clinic project. And this is where we've engaged 330 clinics in our first phase in one of 2 projects, reducing polypharmacy for psychotropics, and also, again, this cardiometabolic choice of antipsychotics for those people who already have cardiometabolic medical conditions. And in this project, we did give clinics a fiscal incentive to participate, and we tracked prevalence and fiscal outcomes in Medicaid, because part of our argument was a return on investment. And then in the next slide, you can see the results for that for antipsychotic polypharmacy. So the blue line is New York City, the green line is the rest of the state, and we can see that at baseline there was nearly 50% more use of antipsychotic polypharmacy in New York City, but that both of those lines drifted down. The solid lines are the participating sites. So even if one region is starting lower than the other, it doesn't mean that they can't improve. The dashed lines are the non-participating, really non-eligible clinics in those same regions. Next slide. And we did see a fiscal impact. So the ones that per person saved the most money, not surprisingly, was schizophrenia. However, it was people with depression who are on this polypharmacy that saved the most money overall for the state because there's just more of them. One thing you'll note, this is year 1 findings, that the first cohort there is youth, and in the first year we actually made no impact for youth, which is why we felt we needed additional interventions, and it wasn't until the second year that we're able to bring benefit to the youth population, which kind of highlighted for us that sometimes when you do interventions that mix both youth and adults, the focus ends up being on the adults and the youth get left a little bit behind. Not a surprise, I don't think, for any child psychiatrists or child folk in the room. Next slide. So some of the lessons learned is that this improvement is possible, that it was very encouraging, that this large steamboat of state Medicaid data that we're actually able to move it through this kind of collaborative work with our providers, but that not all measures improve at the same rate, and that youth needed special focused attention, and return on investment helps to bring support for continued expansion. Next slide. So in the last just few minutes, I was going to share with you some progress on the National Collaborative for Innovation and Quality Measurement. It's a different initiative, but I think related to our topic here today, that it was developed under the Pediatric Quality Measurement Program, was a grant under AHRQ, the Agency for Healthcare Research and Quality, as well as CMS, to develop national measures for youth in Medicaid and in the Children's Health Insurance Program, or CHIP. And NCQA partnered with Nationwide Children's Hospital in Ohio, New York University, New York State Research Foundation for Mental Hygiene, and Rutgers, as well as other stakeholders, including this project, to support the development of measures for youth in foster care and in the general population. We'd say why, in the next slide, we talk about the focus that antipsychotics was one of the major focuses for this InSync project. And part you might say, you know, so how did that come to be? There's an increase in trends with the increasing use of antipsychotics among youth, with a faster rate of increase among youth in Medicaid. And so you might say, well, you know, why is that a concern? So an increase, you know, in the case of underutilization could be good. Some of the concerns relate to the side effects of antipsychotics, and that youth are more vulnerable both to the metabolic impacts, including weight gain and hyperlipidemia and others, as well as to the extrapyramidal side effects of these medications, and that the long-term health impacts are unknown. And there's also some service concerns that the literature suggests that youth are actually less likely than adults to have the recommended laboratory monitoring, despite being more sensitive to those impacts. In addition, psychosocial interventions are underutilized as first-line treatments for aggression and externalizing behavior. And as Christopher had said in his presentation, you know, really antipsychotic practice is often driven by diagnosis of ADHD or these other kinds of off-label use. And if the primary treatment should be psychosocial, that's something that we'd really like to see more of. The regional disparities are marked, and it's not clear that the children vary so much, and that likely this is more a reflection of regional practice variation driven by prescriber preferences, and that disparities for youth in foster care and with developmental disabilities, that we observe much higher levels of use in these populations. So InSync had released for public comment in the past month sets of measures, and there was one sort of set of measures that related to appropriateness or overuse of antipsychotic medications, including use in very young, multiple antipsychotics concurrently, children on higher than recommended doses of antipsychotics, and use of antipsychotics in children without primary indications. In addition, there was a set that related to services, including follow-up care for children on antipsychotics, similar to the existing ADHD measure, as well as metabolic screening for children on antipsychotics and access to psychosocial care for children on antipsychotics. And the next slide shows some of the initial performance that was also distributed for public comment that shows the prevalence of these in a 10-state study. And then just finally to wrap it up, that InSync has proposed these measures, but they will be modified based on public comment, and a number of the states on the phone today, as well as CHCS, had participated in panels that also provided impact and comment. That the antipsychotic measures are generally considered of high importance and feasibility. So NCQA develops many measure sets across all kinds of populations. They said that this was one of the highest levels of interest and comment that they had received in their experience. But the project underscores the importance of state engagement and for state agencies to gain familiarity with using psychotropic measures for youth in foster care. And that concludes my presentation, but I'm happy to answer any questions.
Thank you, Dr. Finnerty. I have two questions for you. Do the in-sync measures specify that only certain diagnoses require pharmacological interventions?
No. So there's one measure there, and just to probably share some advanced press here, that one measure that deals with off-label use, in part because of some of the feedback from foster care, is actually been deprioritized. So that one of those four measures looking at overuse has been deprioritized and will probably not be brought forward as part of the in-sync set. So that was the only one that looked at diagnosis. The notion being that across diagnoses, we might consider it a concern that an antipsychotic was being used for a child who is very young, that it's hard to imagine the diagnosis and that, you know, even so it might merit a review or some attention. The same with polypharmacy, that's a sort of a diagnostic independent concern. So none of the remaining measures actually include diagnoses as a part of the criteria.
Thank you. And we have one more question that we received. What is the method for medication selection in the measurement?
In terms of what's considered an antipsychotic? So the antipsychotic, the list is, I think it was derived, so there's kind of standard kind of systems for organizing classes of medications, but whichever one you choose, it often needs some review and edit. So, for example, just going with FDA's indication or classification as an antipsychotic isn't sufficient. For example, they consider lithium an antipsychotic. So we have a particular set of medications that we are going to classify as antipsychotics that are, you know, part expert review, part existing system. And Christopher shared those, I believe, in part of his presentation, and those will be distributed if they're useful to states in developing their measures.
I think the question may have just been whether NSYNC was looking at all psychotropic medications or those measures are just antipsychotic measures.
Okay. You know, they're all antipsychotic measure focused.
Great, thank you. And if that did not answer the question from the individual who asked it, feel free to email us and we'll get some clarity for you. In the absence of any more questions, I want to thank Dr. Balanci and Dr. Finnerty for presenting during today's webinar. And to those participating in today's webinar, a thank you. The goal of this webinar was to share with you the work being done in an effort to identify and implement common definitions and measures in the prescribing of psychotropic medications among children in foster care. We hope that you found the information presented helpful and that it encourages a broader discussion in your state about this important issue. Can you go to the next slide? Thank you. We have some upcoming CHCS webinars, and I do apologize, there is a typo that should say January 2014. But our next webinar is scheduled for September 2013 on the use and financing of non-pharmacologic EBPs and evidence-based practices, and we will have more information on that webinar in the coming weeks. As a reminder, a video archive of this webinar will be available on the CHCS website. And in just a moment, you will be asked to complete a brief survey which will pop up on your screen. Your feedback is important and will assist in the planning of future webinars. So again, thank you to our presenters and those who participated in today's webinar.